Welcome to Pulse&Pressors, where critical care gets crystal clear. Milrinone is a PDE3 inhibitor, providing non-catecholamine inotropy and vasodilation. Its Inodilator profile improves forward flow and reduces congestion, and because it bypasses beta receptors, it remains effective in beta-blocked patients. Milrinone increases CAMP through PDE3 inhibition in cardiac and vascular smooth muscle. Hepatic metabolism is minimal, while 85% is renally excreted unchanged. Its 2 to 3 hour half-life prolongs significantly in renal impairment, slowing titration and weaning. Blocking PDE3 raises CAMP, improving calcium handling and delivering inotropy, vasodilation, and improved diastolic relaxation. Because it works downstream of beta receptors, it maintains efficacy despite beta blockade. Use Milrinone in cardiogenic shock with adequate MAP, acute decompensated heart failure, RV failure, post-cardiotomy low output, and as a bridge to advanced therapies. It is especially useful when beta blockade renders Dobutamine ineffective. Milrinone increases cardiac output, lowers SVR and PVR, reduces filling pressures, and improves diastolic function with minimal tachycardia. Pulmonary vasodilation makes it particularly valuable in RV failure. Avoid loading doses in borderline blood pressure. Start 0.375 to 0.75 micrograms per kilogram per minute and titrate cautiously. Reduce dosing in renal failure, as accumulation can cause profound hypotension and arrhythmias. Milrinone reliably improves cardiac output and lowers SVR/PVR. MAP may fall if vasodilation outpaces cardiac output. Wedge pressure and CVP drop, relieving congestion, and heart rate usually remains stable. Primary risks include hypotension, atrial or ventricular arrhythmias, thrombocytopenia, ischemia, and prolonged effect due to long half-life. Electrolyte abnormalities, especially low potassium and magnesium, substantially increase arrhythmia risk and must be corrected. The hemodynamic pattern is predictable: increased cardiac output, lowered SVR/PVR, reduced wedge pressure and CVP, and variable MAP requiring vasopressor support in some patients. Heart rate changes minimally. Milrinone is receptor-independent, longer-acting, and more vasodilating. Dobutamine is receptor-dependent, short-acting, and more tachycardic. Milrinone works during beta blockade. Dobutamine does not. Choose Milrinone when beta-blocked, in right ventricular failure, or with significant diastolic dysfunction. Choose Dobutamine for rapid titration, easier weaning, or hypotension-prone patients. In cardiogenic shock with MAP greater than 65 millimeters of mercury, Milrinone improves forward flow and reduces congestion, but often requires norepinephrine. Avoid loading doses in borderline BP. It is preferred over Dobutamine in beta-blocked patients. Milrinone improves pulmonary edema by raising cardiac output and lowering wedge pressure. Use only when diuretics and vasodilators fail, given hypotension risk. Therapy should be short-term, typically under 48 to 72 hours, to avoid the harms seen with chronic exposure. Milrinone lowers PVR and improves RV contractility, making it ideal for massive PE, ARDS, with core pulmonal, and post-cardiotomy RV failure. It often pairs well with inhaled pulmonary vasodilators. Milrinone reduces RV afterload in ventilated patients and can improve weaning in low-output states. Watch for hypotension if high PEEP lowers preload. It aligns well with lung protective strategies. During VA ECMO, Milrinone unloads the LV more effectively than Dobutamine due to less tachycardia. Its long half-life complicates weaning, often requiring vasopressors. Platelet trends must be tracked closely. Beta blockade blocks Dobutamine's receptor pathway, but Milrinone's downstream CAMP mechanism bypasses this entirely. It is the key inotrope for chronic heart failure patients on beta blockers, which should not be stopped abruptly. Renal clearance drives dosing, reduce dosing as creatinine clearance drops, and monitor for prolonged effect. CRRT allows near-standard dosing. Although hepatic metabolism is minor and no formal dose adjustment is required, use cautiously and monitor, as hepatic congestion can slow clearance further. The PROMISE trial showed higher mortality with chronic oral Milrinone due to arrhythmias and sudden death. Intermittent IV outpatient use also causes harm. Short-term ICU use is distinct and appropriate. Long-term ambulatory therapy is not. Thrombocytopenia occurs in a small minority and is reversible. It may be immune-mediated or due to marrow suppression. Monitor platelets daily and transfuse only if bleeding or critically low. Use standard concentrations and an infusion pump via central or peripheral access. Skip loading doses when MAP less than 70 millimeters of mercury. Milrinone and furosemide should not mix due to precipitation. Wean cautiously given long half-life. Milrinone plus norepinephrine stabilizes MAP while allowing inotropy and afterload reduction. An ideal pairing in cardiogenic shock. Vasopressin is an alternative. Avoid phenylephrine because it increases afterload. Monitor rhythm, MAP. A-line ideally. Perfusion markers, platelets, and serial echo or hemodynamic data. Correct potassium and magnesium aggressively, as deficiencies markedly increase arrhythmia risk. Wean in slow 0.125 micrograms per kilogram per minute, steps every 12 to 24 hours. Effects persist after stopping, so ensure stability first. Watch for recurrent pulmonary edema. Transition to oral heart failure therapies as the patient stabilizes. This is Pulse&Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.